so we'll go ahead and get started here. I just want to welcome everybody to our Family Medicine Grand Rounds for today, January 19th. And if you are looking to register for your CME credit for today's presentation, please be sure to use the code here. The instructions are there, but you'll want to go ahead and you can text that code to the number provided. Make sure you do that before midnight tonight. And then this is just some additional information. I don't know if y'all are seeing that or if my windows are blocking that. But this is the activity code. You just text the phone number there and then the activity code for today. We want to thank everybody in advance as we go ahead and get started here. If you could please make sure that your microphone is muted and that you are attentive to the presentation. Our presenters have asked for today, if we could please, any questions or comments that you have, if you could just put those in the chat box, and then we will be going ahead to address those at the end of the session. And then also I will be submitting the link into the chat box towards the end, if you could help us provide some feedback to our presenters as well. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area Health Education Center, and you can see our department's mission statement listed there below for you. CME transcripts are available if you go to our CME's website. You will need that CME transcript if you are looking for AAFP credit. So on the next slide here, it does also let you know that we do allow for credit for this presentation through the AAFP. But if you're having any issues with either CME or AAFP, please be sure to contact me. We also want to make sure that you're aware that we do follow these nationally established physician core competencies. So those are listed there for you to take a look at. We also want to make sure that you know that Dr. Arocha and Dr. Cervantes have no financial relationships with ineligible companies to disclose. So today we have two familiar faces for you. We have Dr. Cervantes, who completed her residency in Christus at their program there. And then Dr. Arocha was here with our program, and both of them did their fellowship in the dermatology clinic. Currently, Dr. Cervantes is with the UMA clinic, and then Dr. Arocha is with WellMed. So I'm gonna go ahead and stop my screen, but they're gonna share for you today the topic of psoriasis for primary care.
Okay, let me see. And okay.
You got it?
And just for some reason it's not. So before it was working, now it's showing you.
I don't see anything yet.
There.
Oh, okay. It started showing.
Okay.
Great. Okay, great. So thanks, Nicole, for the introduction. Adriana and I are going to be talking about psoriasis for primary care. So let's get started. All right, so we're going to review these objectives. Let me get this. I don't know how to get this little camera out of the way so I can actually read the slides. Okay, perfect. We went to the bottom. So we're going to review epidemiology and pathophysiology. We're going to describe clinical variants and differential diagnoses. We're going to discuss topical and systemic treatment options. And we're going to determine associated comorbidities and screenings that we need to do. Next slide. So psoriasis is derived from the Greek word meaning it honestly just means itching condition. It's a chronic recurrent inflammatory rash with an increased epidermal proliferation, otherwise known as acanthosis. It results in an accumulation of the stratum corneum, which then produces the scale. And I'll show you that on a later slide. And then itching really ranges from mild to severe, depending on what the patient presents with. So it's worldwide population, it's about 2% occurrence. Onset, it can occur at any age. It doesn't, prevail in either one sex or the other. Most commonly it is onset and is adulthood. Usually peak ages between 20 and 30 years, and then later in life, about 50 to 60 years. It's associated with psoriatic arthritis in about 5 to 30% of our patients with psoriasis. So there is a genetic predisposition. About 35 to 60% of patients who have psoriasis, if you go into their family history, you'll find out they had an aunt, a father, a cousin, somebody in their family also may have had psoriasis. In a study with identical twins, it occurred in 80% of them, of both twins having psoriasis. So it is multifactorial, like we talked about genetics already. It can be environmental, and I'll go over that, and it can be immunologic, which we'll go over, I believe, on the next slide as well. So basically, as far as pathogenesis, it is a T cell disorder, okay? So it's really driven by these T cell helper cells here. I don't know if Adriana can like circle kind of where we're talking about. The Th1 cells, there you go, and they're mediated by the 17 and 22 cytokines, the interleukins there, which cause the dermal inflammation that's kind of pictured right here on the left, which leads to this dermal inflammation and the keratinocyte replication. Okay, so that's kind of what we're kind of dealing with, and we'll go into this a little bit with more detail on the next slide. So as far as trigger factors, where we talked about environmental or immunologic, so there's something called the Kebner phenomenon. So this is a trauma that can occur to the skin, and someone who's already going to be predisposed to having psoriasis, or someone who already has a psoriasis. So a trauma can happen to the skin, and it's about a lag time, about 2 to 6 weeks before you would actually maybe see some plaques occur in the area of the trauma. Okay, other things that we know about, infections can contribute to psoriasis breakouts, like strep or HIV. There can be endocrine factors like having low calcium levels, and like in pustular psoriasis. Stress makes everything worse in skin. Okay, smoking is also something that can make psoriasis worse. Medications like lithium, beta blockers, antimalarials, all of those can definitely increase risk for having breakouts in psoriasis. Excessive alcohol consumption is also never a good thing, and also in psoriasis. Obesity is also correlated to also worsening psoriasis. So this is that slide that I was telling you that goes in a little bit more detail. So, so we see down here the helper T cells down here, and you can honestly follow all these different pathways. You know, the interleukins 22, the 17, TNF, and all of those causing that inflammatory cascade that's going to cause that keratinocyte proliferation and replication there. And so you have all that skin thickening and erythema. Then you have the neutrophils extravasated from the superficial dermal capillaries, and those kind of invade that epidermis up there. And then those cause those Monroe microabscesses that you see up there. Other things that kind of also affect are the vascular endothelial growth factors, which then produce vasodilation and the angiogenesis, which you see on the lower right-hand side. So in essential, like all of this is why understanding really how the inflammatory pathways work in psoriasis is important, because you'll see, and Adriana will touch on this with more detail later, on why each little pathway is so important, because that's what the treatments are targeting, to really hone in on suppressing this inflammatory process, so people don't no longer have this psoriasis plaques. Okay, next slide. So again, repeating kind of the same thing again. So the end result is an accelerated cell cycle in the epidermis, okay? So it leads to an increased number of dividing cells, culminating in an ordeal of epidermal proliferation. So the cell turnover is increased almost by 7-fold. So normally what you see on the right-hand side with the stratum basale, the stratum spinosum, the granulosum, and the stratum corneum, as it goes up, it's usually a transit time about like 14 to 28 days. Well, in patients with psoriasis, this goes down to about 3 to 4 days. So the process is way too fast for the cells to be shed, which leads to that plaque buildup and all that scale on the stratum corneum. So the different types of psoriasis variants that we'll go over today are plaque psoriasis, otherwise known as psoriasis vulgaris, guttate psoriasis, inverse psoriasis, erythrodermic psoriasis, generalized pustular psoriasis, palmar-plantar pustulosis, scalp psoriasis, nail psoriasis, and then associated psoriatic arthritis. So plaque psoriasis is the most common presentation. You'll find it about 80 to 90% of your patient population. It's usually symmetric, affecting elbows, knees, extensor surfaces. You'll see it on like the gluteal cleft, periumbilical area. So how we describe these, as you guys saw in our previous presentation when we talked about terminology, is description is key, right? So you're going to be describing these silvery gray, well demarcated plaques with an erythematous base. Patients can present with pruritus or without. And then important to also note, as these lesions are resolving, you may have associated post-inflammatory hyper or hypopigmentation without scarring. So here we have an example here on, both of these are, I believe, knees on the bottom left and the top, the right image here on a person with the skin of color. So you may not see that intense red erythematous base that you may see up here on this gluteal area on the top left, but you still see that well demarcation, that thickened plaque with overlying white silvery scales, which is very well easily seen on this left lower hand picture here. So this was actually a patient of mine that I saw 2 weeks ago, which he was very impressive. Psoriasis is seriously something that really affects people's lives. This man was unable to really hold a job. He kept getting fired because they kept saying he was dirty. He was shedding everywhere. He couldn't even maintain like an Uber driver job because people kept giving him low ratings because there were scales all over his car. So this is why this presentation is super important for you guys in primary care to really get started on treatments. Obviously, this man is in need of systemic treatment, and we'll discuss that later. But this man waited in the queue about 5 to 6 months without any treatment and just a skin clinic referral. So that's something that we want to get, ingrained into y'all's brains today to help these people out. Second is guttate psoriasis. This is acute generalized eruption. It's usually presented in children and adolescents. So the guttate comes from like these little raindrop-like papules. They're about 2 to 6 millimeters. It's related to a group A strep infection, either perianal or oropharynx. And it's kind of important to kind of ask, they may not remember like a week ago or 2 weeks ago, but it can be up to 3 weeks prior before the onset. And so you can kind of get that as part of your past medical history. And 40% of these patients do progress onto plaque psoriasis. So here are some examples that you can see here. They're tiny, tiny little plaques, but they do have that overlying like white silvery scale. So they're actually, I think they're kind of cute, but these are both on someone's back. And here are some symmetrically distributed on the lower extremities here. And then on the left side, you have a close-up of those tiny little raindrop little plaques with overlying scale. So inverse psoriasis is usually found in the flexural folds where skin touches skin, so our intertriginous areas. So it's well-defined, shiny pink-red plaques on the inframammary folds, abdominal, inguinal folds, and axillary. Okay, about 30% of our patients have plaque psoriasis. On top of this, these are pruritic, irritated, and often painful because they can actually fissure. And they're commonly confused with tinea or candida. So remember in our previous talk, when Adriana said, if you've been treating tinea for over, a couple of months, it's probably not tinea. So you may want to consider this in your differential diagnosis when you see these next images in your patients. So here's in the groin, you see that well demarcated shiny patch here, and then under the inframammary folds here on a female on the right side. Erythrodermic psoriasis is an acute life-threatening complication of psoriasis. So this is the most serious one that we come across. It's general erythema with scales over 90% of the body surface area, and we'll talk about that later on how you go about measuring that. So triggers are poor management decisions and non-compliance to medical treatment. Sudden systemic withdrawal of steroids can increase, can be like a trigger. Sun exposure. We live in South Texas, so that's kind of hard for our patients to avoid unless they're cooped up inside. It's also the least common form, so don't be too terrified of this. Dehydration and body temperature control is crucial. Fluid management and hospitalization. I remember Adriana and she had a patient who we actually sent to the hospital directly from clinic. They were like, I'm having chills, I'm not feeling well, they're feverish. They got directly admitted for management of erythrodermic psoriasis. So you can see how painful it is on their hands here, and how tense their skin looks, and how erythematous it really is. It's a very serious condition. And so these pictures are actually, the bottom ones are actually from our mentor, Dr. Usatine. I don't know if he's on the call or not, but he's definitely seen tons of these in his work experience. So our next type is generalized pustular psoriasis. So this is an uncommon variant. It's widespread erythematous and sterile pustules, meaning they're not infected, okay? The triggers are infections, corticosteroid withdrawal, pregnancy medications, and topical irritants. So you can get impetigo herpetiformis when it's associated with hypocalcemia and pregnancy. So for your OB population, you may need to consider an early delivery. There's 4 subtypes: generalized, exanthemic, annular, and localized. So here you can see different forms of our variant here. Looks very uncomfortable and painful. So these patients obviously need systemic treatment. We have palmoplantar psoriasis as our 6th time. We're almost through all the variants, guys. Hold on. Okay, so sterile pustules and yellow-brown macules, otherwise known as mahogany spots. And you can visualize these on the palms and soles, and they'll also be desquamation, meaning like the skin is kind of peeling back. Okay, it's usually symmetric, so both palms and soles will be affected on both sides. It's usually more common in women between 40 and 60 years to have their first onset. Triggers, again, are the same as we kind of talked about before. Stress and smoking are never a good thing for anything for health, and during psoriasis, it makes it even worse. Having a thyroid abnormality, and least common, having infections like H. pylori and group A strep also can affect that. It's also associated with plaque psoriasis. So here we can see on the bottom, actually we can see it on all 3 on the pictures here, but you can see those mahogany spots, which are those kind of brownish spots there, and you see a lot of desquamation, and you can notice that it's especially on the pictures on the left, where it is symmetrical on both sides. So that's something to kind of note there, that this is different. Something you may be thinking of is like tinea, right? So desquamation on the feet or the hand, but remember the 2 foot, 1 hand. Here, I'm not sure if this is the same patient, but it's very common to have both soles and both palms affected. So that would be something that may throw you off and think maybe this isn't tinea, okay? Our last one is scalp psoriasis that's really affected on the body. It's considered a special location. It's usually on the back of the scalp, on the occipital region, but honestly, it can be in the frontal. We've seen it behind the ears, and it can coexist with seborrheic dermatitis, where we would then call it something like sebous psoriasis, okay? Next slide. So here you can see the most common is on the occipital here, which you can see on the left-hand side, and the bottom right-hand picture, where you see that well-demarcated plaques with the overlying white silvery scale. here, this poor person up at the top right, you can see that it even comes down all the way between the brows here. But again, important to note how well demarcated it is, right? So this is way beyond a bad case of like dandruff, okay? Nail psoriasis. So 50% of our patients with psoriasis have nail symptoms. So it's important to be checking out people's nails. About 80% of them have associated psoriatic arthritis when they have nail changes, okay? Most common is nail pitting, which is like we'll see in the next presentation, but you can also have onycholysis, subungual keratosis, splinter hemorrhages, oil spots, and nail plate loss. Yeah, okay. I was like, so here you see the nail pitting on that top left is very, very prominent. You see that subungual kind of like debris there. You can see onycholysis, which is like the splitting of the nail. It's just, these nails don't look healthy, right? So if you got a fungal culture and it comes back negative, and then you do a full body exam and you're noticing plaques, and then you have these, you've got a psoriatic nail, okay? So associated, like we said, about 80% with our people with nail changes can have psoriatic arthritis. About 5 to 30% about people that have psoriasis will have psoriatic arthritis as well. So they're going to be seronegative for the spondyloarthropathy, polyarticular affecting hands, feet, knees. They'll have dactylitis. The DIP involvement, nail involvement is related to severity, which we've kind of seen. All of these patients with psoriatic arthritis require systemic treatment. So how do we diagnose? History and physical exam, right? It's a clinical diagnosis. A biopsy is usually really not necessary. In some cases you can, if it's, you know, if you're confused, and there's nothing wrong with that, okay? You always want to do the best for your patient and what's going to get you the correct diagnosis to correctly treat your patient, okay? An interesting finding that you may recall from medical school is the Auspitz sign, right? So when you pick at a scale, it'll bleed, okay? That's what we see there. So here on this side, we'll kind of see the patient severity on what they come in with may not always be as severe as you see it, right? So you may have one patient with one tiny little plaque on their elbow, and for them, it is the most devastating thing in the world. And then you may have a patient like the one that I showed you that I saw 2 weeks ago, who comes in covered, which is also very devastating, but he's like, this is kind of my life. Is this, you know, this is kind of how I've been living my whole life. So it's really something where you have to kind of assess, yes, the severity, depending on body surface area, what you see, whether it's needed topical or systemic treatment, but also how it's affecting their daily life, right? So it's something that you really have to kind of form that bond with that patient to really kind of explore that. Okay, so by just naming them mild, moderate, severe, it's vague because you're not really sure if it's on their end, on my end. And so that's why you come up with these other kind of criteria, which is kind of universal. So body surface area is what we use here in the States. The next one is kind of a combination where then you delve in more to the thickness, the redness, or the type of scale that the person has, and that's more European. The other one, it's not used as much, but it's the quality of life index score. So by using the palm of your hand, depending on obviously the size. So if you have a tiny palm, give or take a percent. If you have a very large hand, also you might be a little more than a percent, but standard is palm of the hand, 1%. Okay, so 1 to 3% is mild, 3 to 10% is considered moderate, and over 10% is considered severe. So differential diagnoses, we know that there's a ton, guys, but you just have to, it's basically by history and what clinical presentation. So here's a big laundry list, but the most common ones that we kind of talked about already were, you know, either eczema, atopic dermatitis, tinea, a drug eruption, candidal fungal infections, okay? But I don't want you to kind of, you know, think that those are the only ones. There's a whole myriad of differential diagnoses, okay?
Okay. Now
Handing off the baton.
So now after that fantastic review of the pathogenesis and the different types, so let's start and check how we can treat our patients. So this is based on the body surface area, as Dr. Cervantes was saying. It involves special areas and the previous response to treatment. So when it's less than 3%, we usually decide just to go with topicals. 3 to 10% is a gray area. Some authors decide it's 3 to 5% to categorize as moderate. So in that one, we can just start with topicals or go with systemics. We have different options. When it's more than 10%, for sure, we go with systemics. Which are those special areas? Our face, palms, soles, genitalia, scalp, and nails. As you can see, are things that are, if we have lesions on that areas, can affect severely our patients. So even having a low area affected, so the impact on their life can be severe. So that's why sometimes we just go directly with systemics, but it's not wrong just to try before topicals. Also, it's good to know if the patient has been treated before and see how was the response. So, and then we can decide. One point, especially on this part, is just to check if the patient was using the correct medication and the correct way, following indications, because sometimes it's a compliance problem more than a failure from the medication. But however, when topicals fail, we need to just jump into systemic treatment. And when as a psoriatic arthritis, we always go to systemic. And this chart summarizes that. So the first question we need to just ask if it's psoriatic arthritis present, if it's just directly to systemic. So when it's no, so we need to assess the body surface area. When it's less than 3%, we can start with topicals or targeted for therapy. And when it's at moderate, so we have that gray area. So we can decide, depending on the patient, in conversation with the patient, just to go topicals first, but it's not wrong just to go and do systemic treatments. So this is our list for this afternoon for the topical treatment options. I'm going to go a little bit more in detail on this because these are the things that we can do in primary care. So, and we can start this. And so by the time the patient is going to be seen by the specialist, he already has some improvement and some treatment, and they don't feel that they have been wasting time. So the first and the cornerstone for the treatment is topical steroids. So we have different classes, and they are based on the vasoconstrictive activity of them. So we have here the list. So we have the very high potent steroids is a class 1. Then we have high potency is class 2 and 3. Medium potency is 4 and 5, and low potency for 6 and 7 class. So I'm going to pass to you one of the multiple recommendations Dr. Usetin gave us, and it's just to get familiarized with one of each class. So that way, you know the presentation, the concentration, and then you can help your patients and just also check if the medication is going to be approved, because it's not helpful if we prescribe something that at the end the patient cannot use or cannot get. Let's talk first about the dark side of the topical steroids. And as we know, they can cause skin atrophy, striae, folliculitis, telangiectasias, purpura, and hypopigmentation. So that's why we need to be careful when we are treating a patient with a dark skin. Also, depending on the area, we can exacerbate acne, rosacea, or any other type of dermatitis. However, we also think the worst about of the topical steroid, but is if studies show that it's safe to use class 1, so the super high potency steroids for 4 weeks, twice a day, without risk of atrophy. Other problems is like the concerns are the suppression of the hypothalamic hypophysis adrenal suppression, and has been reported in multiple studies very low. However, if we're applying the cream to the whole body, or we are doing occlusive therapy, so we can increase the risk because the absorption is higher. Iatrogenic Cushing is very rare. If we apply the cream to the tip of the fingers for a long time, more than 4 weeks, so maybe we can cause one atrophy. It's not recommended, or they have to be very careful and very low potency around the eyes because may increase the intraocular pressure, be associated with cataracts or glaucoma. If safe in pregnancy, if we stay lower than 60 grams per week, which is a decent amount of medication, so it's going to be fine. And also, if we use for a long time, they can stop working, and this is have the phenomenon of tachyphylaxis. So they comes in different presentations. So just to review some of them, ointments are very greasy, as like Vaseline, petroleum jelly. Those are really good when we are hitting very thick skin, like elbows, knees, palms, soles. So they have a very a good penetration, and even having the same concentration can be more potent. Other is a cream, which sometimes is a patient's preference, just because it's easy to be absorbed and is not leaving this greasy feeling. Lotion has more alcohol, so it dries faster. Oil is really good when we are treating scalp, because scalp sometimes just for the dryness becomes very itchy. So that helps, besides delivering the medication, is also helpful. However, solution is sometimes needed, because especially for women, they don't want to be greasy and oily. So we have other options. This is the list that the most common one, and this is the list that we decided that is that we come more frequently. So triamcinolone is a medium potency one, and it's really good when we're treating thinner plaques on body. Clobetasol is 0.05% and is higher, stronger, so we can use in thicker plaques also on body. And hydrocortisone is stronger than the over-the-counter version, which is 1%. So, and it's safe to use in face and genitals in detriginous areas. Remember that skin is thinner, so we can cause atrophy sooner if we don't use the correct one. So, and at the end, those are very good and safe medications if we use wisely. So the thing is just to choose appropriately the potency and the vehicle that we're going to use, depending on the lesion and the location. And also, this is another pearl from Dr. Usatin, go with the patient's preference. So because it's not worth it just to give the best and the perfect if the patient is going to be on the drawer and is not going to be applying the medication. Just to avoid side effects, you can switch to a lower potency one after patient is improving, or can start using intermittently and can just combine with other medication that doesn't have those side effects. This is the next category, calcineurin inhibitors. They act blocking the synthesis of several cytokines, so blocking the whole inflammatory process. They are not FDA approved for psoriasis, and all the information that we have is from studies from atopic dermatitis. In the market, we have tacrolimus 0.02% and 0.1% ointment, and pimecrolimus 1% cream. Those are really, really good on thinner skin because have all the benefits from the steroids, but no the side effects. So we use in combination. Also, we can combine. We have routines like using an steroid in the morning and the other at night, so we can just minimize side effects from steroids. So really good, however difficult to get approved. And so they can cause burning and pruritus, and important just to discuss with the patient before the patient is discussing, having this conversation with the pharmacist, is that this medication has a black box warning because have an increased risk in lymphoma. This is a theoretical risk. Is just extrapolated from the studies done with the oral version of this medication. It's not a reported case from having a lymphoma just using a topical calcineurin inhibitor yet. It can be used cautiously in pregnancy and is safe when breastfeeding, but not avoid the area of the nipple. Other important group is the vitamin D analogs. They go to the vitamin D receptors and they block the keratinocyte proliferation. So we have the calcipotriene 0.05, and that comes in ointment, in cream, in foam, in solution. And calcitriol ointment comes in 3 micrograms per gram. They're really good when you combine with topical corticosteroids because they expose more, so they can penetrate better, and then they minimize side effects from the steroids. So is no evidence of tachyphylaxis. However, they also may produce the burning in the pruritus, some edema, peeling, and dryness. It's more common at the beginning when you use, and once the patients get used to that, after 2-3 weeks, there are minimal discomfort reported by the patient. So it's worth it just to push for them to continue using. If he's using more than 30% of the body surface area, so may cause hypercalcemia. So, and then we're talking, so should be used less than 100 grams per week, which is a lot of the medication. May affect phototherapy effectivity. So because they can affect if makes like a film, so the UVA cannot penetrate, and can also for UVB are affecting. So we can use after the having phototherapy if needed for that specific patient, and not using with salicylic acid because the pH for the salicylic acid can affect the effectivity from this type of medications. Other really good option is tazarotene. This is a type of retinoid, and is affecting the keratinocyte the proliferation and differentiation. We have in 0.1% and 0.05 cream, gel, and foam, and also is good when we combine with steroids. They may cause erythema, burning, and pruritus, and is depending of the concentration. So if we're having good results, but the patient is complaining about this side effect, so maybe we can just decrease the concentration, and patient will have the benefit from this one. And also advise to use moisturizers after the application, and avoid because it's teratogenic, so we don't use in pregnancy. Salicylic acid is a really good keratinolytic agent. Reduce the binding between keratinocytes, so they can just shed easily. It's really good when we combine with topical steroids and tacrolimus. So there are a bunch of over-the-counter presentations, 2 to 10%, cream, lotion. The desal shampoo that we use a lot is salicylic acid on it. And on the problems is when a patient has a renal disease, so may have a higher risk for toxicity, but also is depending of the amount of area that is applying the medication. And can reduce the effectivity of UVB if applied before. It's good if applied after the light therapy. Coal tar have been used for psoriasis for a long time. These coal products suppress the inflammation. We have commercial and compounded preparations. So the problem is that cause a lot of irritation, folliculitis, or like a messy medication can cause also contact dermatitis and phototoxicity. So there is a potential risk for carcinogenesis, but it's not reported. Also, avoid during pregnancy and lactation, can stain skin and clothes, and sometimes patient doesn't like to use because of the odor. One important thing that sometimes we forget is just to prescribe or just advise the patients to use moisturizers. And this is very, very important because that is going to help is rebuilding the skin barrier and reducing the itchiness and the desquamation. And also if we start using it with steroids or any other topical, so we are going to delay a relapse from another flare from psoriasis. So, and this is a list of alternative medicine. Those are not a good proof that we don't have very good evidence that this work. That just to mention just few around the list, the traditional Chinese medicine is basically herbal teas and acupuncture. The problem with this is that patients can have allergy to certain because we don't know exactly what are the components of the tea. So it's not recommended. And for acupuncture, it has not been better than placebo. So is an option, but it's by patient's preference. Aloe vera can be helpful, however, may have risk for contact dermatitis. St. John wort has been good for mild psoriasis, however, have photosensitivity side effects with the oral and also probably with topical presentations. for fish and omega-3 oil as a monotherapy is not good. Those are not good, but can help when you are combining with other treatments. Vitamin D supplements are not helpful. So even though the topical vitamin D helps, the oral is not has not been proven that is going to prevent or help with the psoriasis. Curcumin is an active part of the turmeric, and that can help, but also the same, not as a monotherapy. And these are options that you can use if the patient is declining any medicine. So these are options that you can just advise in case a patient is reluctant to do any other therapy. Zinc is not proven that can help. Gluten-free diet just helps if the patient has a celiac disease. If not, it's not going to affect the course of the condition. And stress reduction, as Dr. Cervantes was saying, yeah, stress can be a trigger for flares. So it's good if the patient can do. And hypnosis, if the patient is hypnotizable. So other than that, it's not going to help. Well, I'm not going to change to the systemic treatment options. So for this, we have great advances in the last 30, 40 years. So we have targeted medicine. So this is fantastic, all the options that we have. We have the non-biologic, all but good medications, methotrexate, acitretin, cyclosporin, a new one, apremilast, and tofacitinib. From the biologic, we have all the anti-TNF and anti-interleukin. We have 3 different groups. We're going to just mention them later. And phototherapy, that is always good, and we have to keep in mind because sometimes patients have some contraindications, so just sending for phototherapy can be a lifesaver. So important to know that we need a previous workup because these medications can affect the immune system. So we need to know how is the status of the patient before starting this medication. The non-biologic agents, all but acitretin and apremilast, will require doing the workup, and all the biologic agents. So, and this is CBC, renal and hepatic function, hepatitis serology, PPD or quantiferin gold, RPR, HIV, pregnancy test, and especially for methotrexate and cyclosporin. So this is a one and good, really good, and old one. So has been forever. So since 1972 was approved for psoriasis, and this acts affecting the nucleic acid synthesis. And initially, was thought that was decreasing the amount of keratinocytes, but is indeed decreasing the T cells, and then is impeding to progress with all the cascade of the immune response. So it's an immunosuppressant. So effective dose are 75 to 25% weekly. That comes in oral, subcutaneous, and intramuscular presentation, and require folate supplementation daily. That is a different, is something that we need to just even when they're coming for a follow-up, the patients just ask how are they taking, because sometimes that can be a disaster and they can call a failure for a good medication just because they are not taking the medication as it's supposed to be, and can be combined with TNF inhibitors and phototherapy. Have a lot of toxicity, so increased risk for infections and reactivations of other diseases. That's why we need to check for HIV, tuberculosis, and hepatitis. Very common GI symptoms like nausea, vomiting, abdominal discomfort can cause myelosuppression, hepatotoxicity, and teratogenic. Contraindications are absolutely pregnancy and nursing. Also patient with alcoholism or any immunodeficiency. And relative contraindications are abnormal liver or renal functions and having an active infection. Require the workup, as we were saying, and every 3 months is recommended to check CBC and CMP. For apremilast, this is a newish one. Is an inhibitor for the esterase 4, is downregulating the inflammatory response. The maintenance dose is 30 milligrams twice a day, but it can be renally adjusted if the clearance is less than 30 to 30 once a day. Is effective for psoriatic arthritis, which is good. It's not that effective than others, but it's a really good option and it's a very safe drug. Side effects are nausea, diarrhea, upper respiratory infections, headaches, weight loss, and depression. So usually are at the beginning of the treatment, but also when the patient have more time taking it, so the symptoms tends to improve. However, if the patient continues with diarrhea and losing weight, and if affecting more is losing more than 5% of the body weight, so we should stop that medication immediately because the patient is not tolerating. And so because of having the risk for diarrhea, we need to be careful treating all patients. Cyclosporin is an really good. It's a very potent T cell inhibitor. The doses are 2.5 to 5 milligrams per kilo per day. It's very effective and is more used as a rescue treatment because it's very fast acting. So when the patients are going to erythrodermic psoriasis, so it's good just to recover the patient for that stage, but it's not good for treating a patient long-term with this medication because can cause nephrotoxicity and hypertension can be very uncontrolled when in these medications. So it's limited to 1 year, or in the USA it's recommended to 1 year and until 2 years in Europe. Requires very careful monitoring and should be avoided in all patients and pregnant patients. Contraindicating if history of malignancy, uncontrolled hypertension, or renal insufficiency. Other old one that now we're using more is an acitretin, which is an oral retinoid, is a vitamin A derivative, and it's really good response in pustular and palmoplantar psoriasis. Also, we need to be monitoring liver enzymes and liver and lipid profile because can affect can increase the triglycerides. Doses are 10 to 50 milligrams per day. Usually you start with 10 and you can titrate up depending on the response of the patient. It's not that effective, but it's not associated with immunosuppression because it's other pathway. So, and can be helpful in those patients that we cannot use those immunosuppressant medications, and can be combined with other systemic drugs and phototherapy. It's teratogenic, can cause a lot of dryness in mouth, very dry skin, and sometimes an alopecia. So patients doesn't tolerate the side effects. As I mentioned, can increase the triglycerides and liver enzymes, and can cause serotomorph-like symptoms. Tofacitinib is also a newish one, is a JAK inhibitor, and is used in psoriatic arthritis, rheumatoid arthritis, and ulcerative colitis. It's not approved for psoriasis, but some patients have comorbidities at the same time, so we have report that is working for psoriasis too. Dose is 5 to 10 milligrams twice a day. If a patient is going to start this medication, it's recommended to give them the shingles vaccine before because it's an increased risk for developed shingles. Can be hepatic and renally adjusted and should be avoided if a patient has an active infection or any hematologic or hepatic disorder. Okay, so that was a non-biologic. Let's move on to the biologic agents, and then we have like 4 big groups. One is TNF inhibitors, and the other is inhibitor for interleukins. So the IL-12/23, IL-23, and IL-17. So those are administered subcutaneously, IM or IV, and as we know, all of them can increase the risk of infections. Lymphoma may be associated to bullous pemphigoid, autoimmune conditions, heart failure, and sometimes is a paradox, but can also patients can develop psoriasis to being on these medications. Those are effective in psoriatic arthritis. As we saw, this is the same that we're seeing at the beginning of the presentation. So you can see here for all anti-TNF, those are the oldest that we have. They affect inhibiting this. So we are blocking all the pathway coming from this. So we are avoiding all that part of the slide. So the pathway. And so they have the IL-23 and the IL-20, 12 and 23 is the kinumab, and IL-23 are newish. So in this blocking this, we are preventing production of interleukin. So all the cascade is discontinued. And we have the IL-17. Okay, so phototherapy. So we have narrow band UVB and PUVA, which is Sorolin UVA. And these are for those patients that cannot tolerate any of the other options. So this is a really good one, especially if they are having after certain age, because that can increase the premature aging of the skin and increase the risk of non-melanoma skin cancer. So we need to decide which type of patient we are just suggesting this therapy. And visible light spectrum is in study right now. Okay, so other, as we know, psoriasis is a complex condition and can be besides the skin, can affect other organs. So other comorbidities associated are like psoriatic arthritis, cardiometabolic condition, and IBD and celiac disease, depression, suicide, and anxiety. So we should be screening patients for this condition because the combination, the presentations at the same time is very common. So these are the recommendations for screening this condition. So all the patients that we have with psoriasis, we should be asking every time that they come to the appointment if they have any joint pain or any swelling of the joints, how they when they are waking up, we have any type of pain on the back, on any other knees or elbows. Consider this condition on all the patients, and evaluate for peripheral inflammatory arthritis, so for say dactylitis and enthesitis, actual involvement. And they have so many questionnaires that you can just give the patient while they are just before you're getting into the room. So that's why you have all the tool fill it, and you can assess that with the patient. You can start treatment for all the patients diagnosed with psoriatic arthritis or refer to a rheumatologist to start it. So this is a very common combination. So cardiometabolic diseases and psoriasis. So they may present a higher risk for myocardial infarction, strokes, peripheral vascular diseases. Patients, they should be informed that this is something that they may have, so they can just take care better of their health. So we need to check and assess as we were doing, and is recommended by the national guidelines, and is in doubt if we should be checking this patient more frequently. And consider for if any screening tool is as concerning, just consider because they can develop a very severe disease. And encourage patients with obesity to maintain a healthy lifestyle. So also is very common the association with depression and anxiety. So every visit we should assess patients with this, with the regular questionnaire that we have with 2 questions, and then progress if it's positive, and refer to the appropriate specialist if needed. Remember that these patients, their life is very affected, and this can just end in a severe depression. Because when they have genitals affected or their face, so that devastate their life, and they can end in having a very sad outcomes. Other condition that we need to just be checking because can be presenting together is inflammatory bowel disease. So if we have a patient with any of symptoms concerning for this, we should refer this patient to the gastroenterologist to check. And remember, patients, IL-17 inhibitors are related with flaring inflammatory bowel disease. So this is not a very good option for them. And this is something very important to discuss right now because we are living the COVID-19 pandemic. So this is the task force, the guidelines. So they've find that that it's safe just to continue with treatment, just to go through this. So remember that when you have the COVID-19, initially is immunosuppression part, and then have hyperimmune response. And then when the hyperimmune response and when the patients usually get sicker. And they share cytokines. So the TNF and IL-17 are overlapping with COVID and psoriasis. And patients have worse outcome if they are also having diabetes, obesity, and CVD. And they found, the guidelines found that it's the same rate of infection and outcomes but it may be affected by some comorbidities. So, and support that psoriasis treatment do not alter the risk of acquire the COVID-19 or the outcomes from having the virus. Patients are not infected, they should continue with the treatment for psoriasis and avoid chronic systemic steroids, because as we were saying, that can just trigger, just flip into the generalized pustular psoriasis or erythrodermic psoriasis. They should follow measures to prevent as any other, just keeping the distance and continue using the mask and avoiding big gatherings. Patients infected with COVID should be managed case by case. So that depends on the severity of the patient. So if it's a patient that is having any systemic biologic agent and having the COVID, but having a good minor symptoms, they should continue with the treatment. However, if it's not, so then it's handle it with a team and they can decide depending of the case. COVID infection may be associated with a psoriasis flare. So it is important to let them know that is not a failure of the treatment. It's just the COVID infection are changing the dynamic of the immune system and they can flare up. Treatment resumption also can be individualized depending on each case. And as advises, just to continue with CDC guidelines. Specifically with the COVID vaccines, patients should have the vaccine. So it's not a contraindications to receive the vaccine, being in treatment with any of the biologic or non-biologic agents. And as soon as they can, they should get it. Systemic medications are not currently, not a contraindication, and is recommended for patients who are receiving the vaccine to continue the biologics. If you are going to start the treatment, it's better to receive the vaccine before and then start. And also because you need to do the workup, you will have time just to receive at least 2 doses and then start the biologic agent. In the case for methotrexate, sometimes most rheumatologists, they stop 2 weeks after giving the influenza vaccine just to have a better response. This is something that can be done, but
oh my gosh, why is it so loud?
So and you should discuss this with the patient because it's a shared decision. Prognosis depends on the type and the severity. Patients' compliance to treatment is crucial, so we need to explain them that this is a chronic condition. They can be flaring, even doing everything that they are doing. Erythrodermic and generalized psoriasis require immediate attention. This is an emergency, and sometimes plaque psoriasis can be a challenge. It's very important to monitor these patients and how we know if the treatment is effective. So if we are having less than 3% of body surface area or a 75% improvement, means we are treating correctly. So this is our goal. This is the treatment goal. We should always monitor for medication side effects and check CBC, renal, and liver function as indicated. And education is very, very important, as I mentioned before, and set realistic treatment goals, because sometimes patients are frustrated because they think they are not going to have ever again. Sometimes that happens, but sometimes it's not, and they need to know that we can manage this condition, but to cure this condition is not in our hands. So, and promote skincare. So just always recommend just to use moisturizers. Treatment adherence and should be emphasized. And there is a support service and the National Psoriasis Foundation, which is here. So this is a web page. So you can just get there, and patients can just have chats and groups, and they can share all the concerns that they have. Refer to dermatology when you have an unclear diagnosis. If the body surface area is more than 3%, more than 10% or 2% and not responding to treatment. If nail involvement is present, because we need to determine if there's associated psoriatic arthritis, and immediate if it's erythrodermic or generalized pustular psoriasis present. So in summary, finally, this is the end. In summary, so psoriasis is a chronic multisystemic disease and mainly affect the skin, but also be affecting other organs. So that's why we need just to be monitoring for other comorbidities. Plaque psoriasis is the most common subtype. When nails are involved, just check for psoriatic arthritis. Less than 3% body surface area, so can be treated with topicals. If you require a specialist referral, start topical treatment and skincare measures, and then send to the specialist. There are multiple, right now we are spoiled, so we have multiple options to treat psoriasis. Oral steroids should be avoided to treat this condition. Monitor and control associated comorbidities, and promote lifestyle changes. And so this 30 patients and the skin clinic, what can do I in your clinic, what can you do? So just check first if you have the correct diagnosis. It's good if you can take pictures and you can upload to the system, because it's easier for the person who's going to review the chart, already having some information from before the patient arrived. Educate patients, as I said, so realistic expectations and goals. There are great handouts in Epic, so you can just print that and give it to them. Try topicals, steroid first, and you can have, as we were discussing, a bunch of other options that you can combine with those. If the patient, they don't improve with treatment after 4 or 6 weeks, just consider refer to the skin clinic just to improve the treatment. And if you think that a patient will need a systemic treatment, and sooner, you can call the skin clinic just to set up a faster, sooner appointment, and just check that vaccines are up to date, included COVID series, and you can order, if you're sure that the patient will need a systemic, just go ahead and start the workup that is needed. And this is how you can contact us. Dr. Cervantes is a part of the system, so you can send the MRNs of the patients and a message, and she's going to be happy to help you.
Yes.
Thank you so much for being with us this afternoon. And these are all the references that we use it. And we are happy to answer any questions if you have. I don't see the chat box.
I think they're all, I don't think anyone wrote anything. I think we tired them out.
There are a lot of thank yous. So I know everybody, a lot of information, but it looks like everybody was very grateful for all the information. I don't know if anybody else wants to comment or unmute. Please feel free to do so.
I just want to add my thank you personally. It's always great to have former grads come back. And so thank you for that thorough review. Jimena, thank you for supporting the education of our residents. I greatly appreciate it.
Sure thing. Anytime.
Dr. Nato, the level of evidence of those comorbidities assessments was just dedicated to you.
You know, I like that, right?
Yeah, I know.
Put it into that famous box and then we can review it. Right?
Those are, yeah, yes, sir.
Okay, if anybody has any questions, please feel free to reach out to them, or you can contact me as well for their information. I want to thank you both very much, and thank you everybody for joining us.
All right,
Bye,
thank you.